today we have Sunil Goria sir with us. Sunil sir is Bachelor of Occupational Therapist from New Delhi and he has completed his PGDR from Mumbai. He is presently working as occupational therapist, chief occupational therapist as Blind People's Association, and he is also acting as visiting faculty for KP Patel College of Occupational Therapy, Anand. He is having more than 20 years of experience in the field of occupational therapist, and he is awarded by Best Occupational Therapist by Gujarat branch in 2020. Sunil sir today is going to focus on the sensory issues in the children. As we all are aware that normal sensations play a very important role in normal growth and development of the child. How sensory issues can be evaluated, and as a team member of multidisciplinary team, what will be the role of occupational therapist in assessment of the sensory issues in the children, and how as a physiotherapist we can deal with the sensory issues. So thank you very much, Sunil sir, for accepting our invitation and sparing your time for this webinar. I hope students will get knowledge regarding the sensory issues in the children from the perspective of the occupational therapist. Over to you, sir.
Good morning, madam. Shall I start?
Yes, sir. Yes, sir.
Good morning, madam. First of all, I would like to thank you and Bhavna madam to giving me this opportunity so that I shall be able to present occupational therapist perspective on sensory issues which are found in children. And a brief introduction of myself, as you have already introduced myself. I am occupational therapist from passed out from IPH New Delhi, and then I did my PGDR from Mumbai. And from 2012, I am working with Blind People Association. All along, I have worked with children and in various NGOs. So we will start today's deliberations, the sensory issues which are commonly found in children and how it affects the development. So before actually going into the deliberation, I would like to share two cases which I saw very early in my practice and which aroused my interest in sensory integration and sensory development. One was when I was working in an NGO, a small child came in the he was his mother in the mother's lap, and the mother was carrying the child, and he was around 2 years of age, but he was not walking, and the problem with the mother came that the child is not walking, but they came for assessment, but the child was not ready to come to us. He was clinching his mother, and whenever we will call, he will start crying, and he was clinching the mother tightly. He was just not ready to come on the mat. So any intervention, whether by occupational therapist or physiotherapist, or for that matter for a special educator, it was not possible because he was not ready to come to us only. So that was a very puzzling type of uh, behavior which was shown by the child, but that was around 20 years back. It is not nowadays. It can be understood very easily, but 20 years back the scenario was not that much clear. And another child came who was Down syndrome girl, around 7-8 years. Now, as all of us know, that Down syndrome children, they have hypotonicity and weakness related problem. But this child came that she was standing reluctantly, and she was very reluctant to take any step. So motor wise there was weakness, but not that much that that child will not be able to stand and walk. But there was great reluctance from her part to uh, stand independently and walk independently. Now, when we observe both the children, motor wise, there was not the issue which the child was showing in their behavior. So that must be the presentations of many children what J. Ayer has saw, and that's why she was the pioneer in 1971. Around 1971, she conceptualized the whole idea that why certain children behave in a atypical manner, and she developed sensory integration theory or sensory integration therapy. So my presentation is based on the work which was done by Chia. She was the pioneer of sensory integration therapy. It is about atypical behavior shown by children, which cannot be explained by their motor behaviors. So what J. Iyer has explained that what causes sensory issues, why certain children behave in an atypical manner. So what she has conceptualized that our brain is constantly receiving informations from surrounding and from within the body, and that's why we make a sense out of whatever we perceive, and we receive informations, sensory inputs through five direct senses, that is vision, hearing, taste, smell and touch. So it is clear that what we see, what we hear, what we taste, what we smell, and the things which touches us. So through this we get our brain receives sensory inputs, and we the brain also receives sensory inputs within the body, that is the vestibular system, which is the located in the inner ear, and it is responsible for balance and our connection with the earth, that is gravity and gravitational security. And another system is proprioceptive system, which is sense of position of the body. Now proprioceptive systems, the receptors are located in the joints, muscles, ligaments and tendons. So uh, our brain constantly receives informations from inner ear, that is the vestibular system, and proprioceptive system also. And the eighth sense is interoceptive system, like which are the inputs we receive through our vital organs, that whether we are thirsty, whether we are hungry, whether we want to sleep right now, or whether we want to go to micturate, those whether. So these things also affects the our motor behavior or behavior, simply behavior. Now imagine all these uh, all these sensory inputs our brain is receiving, and the main thing is processing. So processing is the main thing. If the processing is typical, the motor behavior will be typical. But if the processing is not typical, the motor behavior will be dif- different, and the child's behavior will be atypical. So suppose right now when I am presenting this, I am looking at the screen, that is the visual sense, and what I am saying, I am hearing, that is the auditory sense. Here olfactory and gustatory senses are not working, but the way I am putting my hand on the table, or where are the positions of both my hands, that is the proprioceptive sense, and I am sitting maintaining the balance, that is vestibular sense. What I mean to say that uh, most of the time our brain is receiving inputs through multiple senses, and it is processing and making sense of the whole thing, the whole work, whatever function we do. Now most of the functions we do, the our brain receives informations from outside body, from within the body, and it makes sense that how to respond, and that the this processing is which makes us enable to do to respond effectively. Now this is what is the basics of sensory integration therapy. Now interoceptive system, how it is working, that I am comfortable with the lighting arrangements, I am comfortable with the my my uh, arousal level, and I am comfortable with my inner system which is working, so I am able to respond in a appropriate manner. Now imagine a situation where a child is hungry, and I am telling the child to come to me, and I have a orange with me, and I am telling the child to come to me and take the orange and eat it. So a child who is little bit far from me, he listen to me that what I am saying, and he looks at me. Then he comes to me. He holds the orange. He opens the orange, peel it off. He eats it, and this is the way he performed this task. Now, this is a very simple and day-to-day activity which everybody requires to do. Now, when what I'm saying to the child is listening, and the instructions what I'm saying is his auditory sense. When he's looking at me, that is his visual sense, and when he comes to me, that is his vestibular sense. And the way he is holding the orange to peel it off, the way how much force he's applying and how much adjustment he is making in his muscles to hold a orange like a orange and not like a cricket ball or like a watermelon, that is the proprioceptive sense. So basically proprioceptive sense has two functions. One is gradation of force which we require to perform any activity. We always grade our force to smoothly function. Suppose we have to if we have to if we have to drink tea from a cup which is a, a, a soil material, so we will hold it differently. We will apply a different amount of force to hold it, to adjust our fingers. But if it is plastic material or it is thermocol material, we will reduce the amount of force in our finger to hold it. We'll make the adjustment, that is proprioception. Suppose we are going down the downhill, then we are contracting our leg muscles to slow down our speed, that is proprioceptive sense. So one function of proprioceptive sense is adjustment of force or the gradation of force which is required to perform a task. So if a child has to hold a orange, he will hold it in a different manner. If he has to hold a cricket ball, he will hold it in a different manner. The amount of force will differ. So in this example, the child holds the orange like he is holding a orange and nothing different. So that is his proprioceptive sense, and the amount of force he requires to peel it off, that is the proprioception. The touch, the texture of the skin of the orange is the tactile sense. And when he, as soon as he peels the orange off, the aroma spread out, that is the olfactory sense, and when he eats it, that is the gustatory sense. So if in this example, if you will see, all the senses are working, and the brain is receiving input, and it is integrating, processing all the informations, and the child is able to eat the orange and he is able to satisfy his hunger, that is the interoceptive system is able to manage. So this is a typical behavior, typical response. But if the processing is different, then suppose whatever I am saying, the brain is not processing it is an in appropriate manner. He may not register what I am saying, so he may not respond to it. So suppose if whatever he is looking at me, he is his the vision is not processing appropriately. He will look here and there, or he will just stare at me and he will not respond. Similarly, if his vestibular sense the processing is not appropriate, he will not take steps further to come to me, so he will not come to me, and his proprioceptive sense is not processing, the inputs are not processing in the brain properly appropriately. So instead of holding it softly and opening and peeling it off, he will just crush the orange, and you will not be able to eat it. And if the olfactory the inputs are not processed appropriately, the smell can be nauseating and it can be too much for him, and he can just start feeling nauseating or he may vomit. Similarly, if the taste the gustatory inputs are not processed appropriately, then he will not feel as if he is eating a sweet orange. Instead, he will feel like he is something is very bitter in taste, and he will just put his hand like this, and he would not like to eat it. In our clinical practice, many times we see some children who are behaving in this manner. Many times we'll see that children, when they come to clinic or in the classroom, the teacher is saying or the therapist is saying, but he is not responding to his name. And child wants the therapist wants his attention to look at particular object. He is not looking at that. He is avoiding. And many times in our clinical practice, we see that without reason, child is fearful of taking steps. Standing, he is too much scared of standing. In our clinical practice, we see that children who are unable to handle fragile items, they are not able to appreciate their position of their body parts, and that's why they have bilateral integration problems. They don't know where the two sides of the body is there. So whatever task we do, they will do it with one hand. And as physiotherapist, you will see many type of cerebral palsy children also. They are having poor proprioceptive processing. So they will, if you work on them, they will be nicely doing things by one side, but they will very with much difficulty they will involve their both sides. So bilateral movements will be very much difficult in them. So that is again a proprioceptive problem, because proprioception has two functions. One is to adjust the muscle force. Second is it gives us the idea of sense of position of the body. So when I am aware the where is my right side, where is my left side, I am aware about my whole body, whole body existence, how it is existed, and where are my different parts of the body. Now when I am aware about my different parts of the body, right side, left side, I am able to do things which require bilateral movement. I am able to I am able to do play activities like catch and throw, because they require movements from both sides. And I am able to respond to situations where things are coming to me. Then I am aware about my body, I can make adjustment, I can move here and there. But if I am not aware about my clearly about my uh, body, the our different both sides of the body, then what will happen if something comes in between or something is approaching to me? I may not respond appropriately, I may bump into things, I may not my actions will not be smooth. So in our clinical practice we see that if processing is not adequate, then children who comes to clinics or who comes to therapy centers, they behave in a atypical manner, and is because of the processing problem. This is what J. Ayer conceptualized. Now, if the processing of sensory input is not appropriate, then there are three types of uh, problems, or three types of atypical behavior are presented by children. That is sensory modulatory disorders, sensory discriminatory or perception related problems, and praxis, that is praxis problems, that is planning issues. So in clinical setups, mostly we see children with sensory modulatory problems, sensory discriminatory perception problem, and praxis problems. This category of children we see in school setups, or those who are little bit able to do functions, but in clinical setups we see children with sensory modulatory problems. Now modulation is adjustment and response of sensory inputs, and its judgment. It's about the judgment about the sensory inputs. The sensory input the brain receives in the form of, basically in the form of touch, vestibular and proprioceptive. So it tells us that how much amount is the inputs is there, and whether it is safe or not safe. So this judgment is modulation. And if this modulation is not there, then the child will not be able to judge whether this amount is safe or unsafe, and he will respond in a typical manner. So mainly two types of behavior is shown by children who are having modulated problems. They become over responsive if the input is normal, but the brain is processing it as too much. Then what happens that a very harmless and normal type of input is perceived by brain as something abnormal and too much, which can be painful. So what happens that there will be defensiveness and the child withdraws. So he won't like to use those inputs into and process it and respond to it. So they become defensive. So we see children who are tactile defensive, who are visual defensive, who are auditory defensive, who are vestibular defensive, who are proprioceptive defensive, who are gustatory defensive, who are olfactory defensive. Many times we see in a normal in a children where in a room where the light is normal, but the child covers their eyes because the normal light is too much for them. The brain is processing it to be too much, so they will cover their uh, eyes, or they will close their eyes so that less amount of light enters them. But in our clinical practice, the mostly we see children with tactile defensiveness. Those who are not comfortable with the touch. Now again, it has two parts. Tactile defensive child, they may touch to other people, but they do not like to be touched by other people. So sometimes it creates confusion in our clinical practice that we say that no, this child is not tactile defensive. He likes to touch everything. In fact, he is seeking something like that. But the thing is, you have to see whether he likes to touch or he likes not to be touched. Suppose he touches you, he touches the toys, he touches parents, he touches mat, that's okay. But what is his response when you touches him? So if that time, if the response is exaggerated, then he is a tactile defensive child. And this type of children, they show learning problems because they do not like to mix. They do not like to come close to therapists. They do not like to come to surfaces. They avoid surfaces. They avoid different type of textures, and in extended form that can cause oral hypersensitivity. So this is hyper responsiveness, over responsiveness, and defensive behavior. So in touch, we see in our clinical practice tactile defensive children, they are very common to see. And in very if the this tactile defensiveness is not too much, then in fact it is very difficult to assess also, because they appear seems to be normal, but their learning is learning of new skills, learning of motor skills can be delayed. And we even do not know why it is getting delayed, but why he is not interested. But if you see minutely, if you observe minutely, you will realize that he is a tactile defensive child, is not comfortable in when the different textures are he is exposed to different textures, and that's why he is not interacting in the environment. So that is tactile defensiveness. Another very common type of defensive behavior we see in our clinical practice is vestibular defensiveness or vestibular hypersensitivity, in which there are again the vestibular things. It is two types. One is balance. So the child is all the time our balance is challenged when we are changing our position from sitting to standing or sitting to moving, or when moving indoor outdoor, the change in the depth of the surface. So all the time the balance is challenged. So these our inner ear is it is noticing, and we are making our adjustments to that. But if that is not that is the minor change in the position or minor change in the surface is perceived as too much, and too much dangerous, then the child prefers to remain in a one posture. He won't like to change his position. He won't like to walk on the surfaces because there are variations in the depth of the surfaces. And they ultimately, if you grossly see, they will not like to move around. They won't like to uh, change the position of the head in response to the earth. So they are also very common to see. And second, the function of the it's the gravitational security, that uh, the with the relation with the earth, that the a child who is having gravitationally secure means he is comfortable in the ground, at the ground, and in the walking and in the running and all those things. So he's a secure child. But because of vestibular hypersensitivity, if gravitational insecurity is there, so what will happen, that we will be highly insecure. And I had told that gravitational security is must for proper development, proper exploration. Because what happens that when a child becomes defensive, a child job is to explore and learn. But when defensiveness things overtakes, then the child is not moving around, not exploring, but his whole energy is going to making himself safe. So that's why his learning is affected. So in our clinical practice, we get a lot of children who are having vestibular hypersensitivity without any motor problem. Means if you see tone of the muscles, or if you see a strength of the muscles, they seem all right, their cognition seem all right, but they are not able, they are not willing to stand, they are not willing to walk, they are not willing to change the position of the body. So that is vestibular hypersensitivity. And recently I saw, because of the lockdown, the children who are not coming to the centers. And what we are doing, that we are providing online services, and we are guiding parents to do these activities, how to reduce the sensory problems. But few months back, when the situation improved and they started coming to centers, what we realized that their sensory problems have increased many folds. So I saw a child who has vestibular hypersensitivity issue so much increased that when he is lying supine, he has to lift his leg to go to sideline or to prone. Even that much amount of separation of his leg from the earth he was not able to tolerate, and he was crying profusely. So that is vestibular hypersensitivity at a very gross level, very increased level. So that is the, again, it is commonly found in the our clinical setup. That is modulatory problem, hyperresponsiveness. And if that is auditory, means auditory hyperresponsiveness means you must have seen children who are covering their ears in a normal environment also, or if the pressure cooker, with the noise of pressure cooker or grinder, they immediately cover their ears, because that is auditory hyper responsiveness. And similarly, if that goes to oral muscles, then oral hypersensitivity is there. They are fussy eaters. Certain texture they will like, certain texture they will avoid. And that because, and one thing is there, that our sensory system, it is working in a group, or in a pair. Very rarely it works, on a to single basis. I mean, vestibular sense and proprioceptive sense, it works together. Because if you have to maintain balance, you must know where are your positions of the body. Similarly, vision sense and auditory sense, it works together. And gustatory sense and olfactory sense, it works together. So suppose if the smell is too much, then also child will not eat. The olfactory hyperresponsiveness is there, the child will just put it like this, he will show that he is not interested. And if the gustatory thing is too much, then the normal test will be too much for him, and he will be a fussy eater. He will just avoid it. That is hypersensitivity of oral structures. So that's how we see that children who are having hyper-responsiveness and defensive behavior, they show clinical problems, and it is not directly related to their motor problems. Similarly, there will be hyper-responsive. Bright light will also not create any type of arousal in visual arousal in the child. That is because lot of light lot of light arrangement is also not, the brain is not able to process it in appropriate manner. And similarly, too much noise the child is not bothered about, and he will be doing fine with that. And you'll see that if there are a lot of changes in the surfaces, up down is there, the balance is challenged, but the child is not bothered. Even if he's falling, it is okay. He's not falling, it's okay. And he's not concerned about falling down and all. But it is different from seeking behavior, so we have to be very clear about it, what is hyper responsiveness and what is seeking. Similarly, tactile type of hyper registration is, or hyper responsiveness is, you pinch the child strongly, or the child has crushed his fingers but he is not responding. And so such children, what they do, they deliberately irritate others, because when the others respond to him, they are not, it is not coming to uh, any problem for the child, so he enjoys in this manner. And they are generally, we see that such children, those who are having hyper responsiveness and poor registration, so they are reluctant type of children. They're those who are not interested in surroundings, because when a child is very small, he plays with the light, with the sound. But because of poor registration, these type of toys do not create any interest in the child. So they are not non-responsive type of children. And if proprioception is there, so what will happen, that they are not their brain is not uh, processing it. If they are falling down and if something is pressing, then they are not responding. Their posture is down, their posture is bended, and it's not properly, the tone is less, and they appear clumsy. They are not well organized. So that is because of the hyper responsiveness and poor registration of the sensory inputs. Sometimes sensory inputs are processed. So, as we all know that sensory inputs we all require in certain amounts, and our brain processes it, and then we it's satisfied that we also need movement. We also need to move around. We also need pressure over our joints. We also need to touch or feel different textures. We also need to taste, to eat, all these things, all these inputs we also require. But after a certain period of time, when our brain has received these inputs, what happens that we are satisfied, our brain is satisfied with those type of inputs, and then we settle down to do important works, do important functions, or to learn new things. But in some children, what happens that their brain is not satisfied with the amount of input they receive in day-to-day basis. So they crave for more and more and more of sensory inputs, and then they show sensory seeking behavior. So a tactile seeking child, he would like to devote most of the time in feeling the different textures of the things which are presented to him. So suppose he comes to your clinic, so he will be more interested in different type of toys, but not to play with them, but to feel their texture, their shapes and all, and they will go on exploring them. And even if you demand that no, you stop it and look here and you do this one, but they will be lost in exploring the textures. So they will be, or they will be, when they come to clinics, they go on touching everything, touching therapists, touching desks, touching mat, all those things. So they are tactile seekers. Similarly, vision thing. So whatever, they will be looking at the light and they will be jumping and they will be fascinated by the lights. So suppose if you take him to a mall where different type of lights are there, so that will be a treat for them, and they won't be interested in coming with you or going to do my shopping and all, but they will lost in looking at different type of lights. So similarly, if their music is there, so seeking for music or sound, so they will be lost in music, or they can pick up musical tones from far off places, and they go on lost. They won't focus on the work. They won't focus on the task which is in the hand, but they will be lost in the sound or the music which is coming, and they will be fascinated by that. Similarly, if their proprioceptive seekers are there, so what they will do, they will try to get every opportunity to get themselves compressed. They will compel others to press them, or in activities which creates pressure over their joints. And similarly, if vestibular seekers are there, so they will be jumping all the time. They will be seeking movement. So we see that this child is hyperactive child or motor restless child. So unless until they do lot of movement, their brain is not satisfied and they will crave for more and more. So modulatory problems are these three types of modulatory are manifested, clinically manifested. One is defensive, other is clumsy or non-responsive type, and third is seeker type, which is seeking, craving for more and more and more. So just as I told that some children who are tactile over responsive, so they will avoid messy play. So the children who comes to us, the parents will complain that he does not like to eat chawal dal, but he can eat dry snacks. And even in normal schools also, you will see some of the children who prefers to sit alone. They prefers to eat alone. They prefers to remain alone. They don't like to mix up with other children, or they don't want to play with other children. And this is very commonly found in children with spectrum disorders. They are too much distressed by certain clothings which are tight or which has texture, which can be little demanding. So they won't like to wear those dresses. So they are distressed by tight clothings. And this is again very common that they refuse to walk on certain surfaces. Suppose if you take such children in the park, so the touch of grass will be too much. They will keep their foot up. Many times it will appear that they are walking with plantar flexed uh, foot, but in fact they are in that time they are avoiding, they are minimizing the contact. They won't like to play in sand, they won't like to walk on the sand, so they are tactile over responsive child. All this is disturbs the typical response and affects the learning. Now, under responsive children who are not bothered by injuries, I saw a child who is under responsive hyperregistration of tactile thing is there. So pain is also under registered. So what happened that the child was going on the with their parents on the bike, and with the silencer she got burn injuries, but she was not able to uh, respond to it, and she got a lot of burn because of that. Even she has this habit of irritating other persons around him, because what happens that if she is irritating other person and other person is responding by holding her hand or punishing her, she is not feeling the pain, so it's okay for her, so she goes on doing this. So such children sometimes they show self-abusing behaviors. They can bang their own head on the ground, and which can be painful for others, but which is okay for them. And third is sensory seekers who are always on the go, jumping, climbing, asking for body compression, because such children, many times you will see that some of the children who will come to your clinic setups, they will come and they will just collide with the therapist. They will go deep into the therapist position or the other person's position or the parent's position, so that see they get the necessary compression which the brain is craving for. Similarly, tactile seekers, they go on touching different textures. So they are seekers. When you see a child who is asking for more and more and more of any sensory inputs, they are seekers. Now, this is related to academic sensory discrimination and perception problem. If sensory modulation is okay, then comes sensory discrimination and perception. That is, the discrimination is our enhanced sensory, uh, enhanced capacity of the brain to discriminate between same inputs, same sensory inputs. For example, if I am looking at alphabets, and if I am able to see M and W different, that is my sensory discrimination skill is, sorry, my visual discrimination skill is all right. So suppose if I am able to move around and I have to reach a destination, and in one attempt I am able to find the path and I am able to figure out that how to go to that place, that my visual discrimination skill is all right. Suppose in a cluttered toy, if the child is able to find out his favorite toy, that is his visual discrimination skill is all right. Similarly, if walking on the surface, if I am able to notice minor changes in the depth, that is vestibular discrimination skill is all right. If I am able to discriminate or able to understand that how much force I shall be grading to perform a very gentle task to a not so gentle task to a crude task, that is the proprioceptive discrimination skills. If I am able to understand the tone of the voice, or the if I am going on the road and I am able to understand the the sound of a siren, a ambulance or a police siren, that is my auditory discrimination skill is all right. So these skills are required in the academics, because when you have to copy down, you have to see that PQ, MW, all those things. You have to also visually discriminate that what on the blackboard what has been written, and you have to copy down. So how much space you have to leave and how much columns you have to maintain, that is the visual discrimination. So this skill is related to academics. Perception is and cognition is knowing about the thing, and perception is knowing in detail about the thing. So suppose if I know that this is a laptop, this is my cognition, but in this laptop what are the features and how to operate those features, where is green, where is blue, where is black, where is light coming, where is music coming, that is perception. So that detail, getting detail informations is through the inputs, through visual, through proprioceptive, through tactile, through vestibular, is sensory discrimination and perception skills. And because we work with children of all ages, so we work in a school setup also, so we have to see that many times children who are poor in academics, poor in writing skills, poor in maintaining columns, poor in maintaining space, poor in copying down. So that time teachers, we have to guide teachers that they are not doing deliberately, but this is because of the problem in sensory integration. And that's based on if the modulation is okay and the discrimination is okay, then comes praxis is planning. Suppose everything means if I tell a child, ki, you just do this form activity. So for doing this form activity, he has to conceptualize that there will be different pegs. Which peg will be placed at what place? And he has to conceptualize, then he has to plan, and then he has to execute. So every task is praxis, that is planning and execution and ideation, conceptualization. So suppose if I have to present this presentation, so what I have to do? I have to form an idea that what is it all about. I have to plan that which slide will come when, and then I have to execute. But for that, my sensory modulation skills shall be all right. Then my sensory discrimination skills shall be all right, and then I will be able to do this higher function. So if children has problem in sensory modulation, children has problem in sensory discrimination and perception, then definitely they will be having problem with praxis. So some of the children we see, they are not able to plan. Suppose I will take come to third floor, but they are not, they're lost in the ground floor, how to go to third floor. So that time they are not able to plan, they're not able to conceptualize, not able to plan, and not able to execute. So it can be due to sensory problems, and we have to help there in the planning and in the conceptualization and the execution. So that are the main three type of sensory processing problems. Now, sensory. So if the such children comes, and I will be restricting this to sensory modulation. That sensory integration therapy, the J. Iyer proposed that sensory integration therapy for this. That the this is a highly a creative type of therapy in which it's not like key for this you do this, for this you do this. It's a lot of freedom has been given to therapists to to develop their own ideas, their own methods to resolve those issues. So suppose in modulation we have three things, that is hyper response, that is defensiveness, that is under registration, and that is seeker type. So if the more type of children we are seeing is the defensive child, so what we have to do, our theory shall be based on these three principles which were given by Chair. That is, it should be our therapy should be just right challenge. The challenge we shall give, it should be the just right. It has two parts. One is that which system you are targeting. So we have to see that which system is affected, tactile system is affected, or vestibular system is affected, and proprioceptive system is affected. What system is affected? Then uh, we have to address that system. But in general, what we see that for every problem, mostly we work on tactile, proprioceptive, and vestibular system, because ultimately occupational therapy is function based, and to perform any function you require integration of tactile, vestibular, and proprioceptive system. Suppose you have to write. When you have to write, you have to touch, you have to see also, but without seeing also you can write. You have to hear also, but without hearing also you can write. And touch and taste and smell is not required, but what is required is touch. You have to touch the pen, you have to touch the notebook, and then proprioception, how much force you will by which you will hold the pen, and vestibular system, that is the balance. So basically we are focusing on three system because we are focusing on function, we are focusing on tactile, proprioceptive, and vestibular system. So just right challenge, address the uh, sensory skills which are affected, then it should be at that level. Suppose if a child is very much scared, so what happens that if you will give too much of a stimulation, then his problem will increase. And then next principle is active involvement. So you have to devise the whole therapy plan in such a manner that child shall do it on an active manner. You, our role is will be there. We can do passively, we we can be there, but we have to see that child is involved in the process, and for that we have to use play way method, outdoor play, yeah, indoor play. So when we use outdoor play or indoor play, whole sensory system is challenged, what we want to challenge in a active manner, because active learning is more learning, passive learning is less learning. And look for adaptive changes. That suppose if you want to reduce the tactile defensiveness, so after the session his defensiveness shall reduce, it shall not increase. So adaptive changes shall be there, means child must be feeling more confident, more happy after the session. The goal of sensory integration is the child shall be more comfortable in the environment. He shall be more happy in the environment, because a sensory child is not a happy child, is not very comfortable in the environment, especially those who are having defensive type of problems. So we have to do like this. So as in the beginning, I discussed two children. One was the child who was 2 year old, but he was not standing and walking. And when the child came with the mother, so he was clinching the mother. He was not ready to come there. So he was basically a tactile defensive child, and we worked on his tactile defensiveness. And I'm giving you this example as a case study that there shall be a strategy to address these issues. There's not that you apply brush and all and the things over, but we formulated a plan with our team that how to address his tactile defensiveness. What we did, we make the child sit in a corner with the mother because he was comfortable with the mother, and we make him play with the mother. So because he was comfortable with the mother, so that was okay for him. Then we selected a therapist. Slowly she introduced herself with the child. She went into his comfort zone, and gradually they started creating opportunities where the child has to touch the therapist, for example, to taking a toy or giving high five, something like that. And that's how his defensiveness reduced, his confidence increased. And then the actual work, the actual therapy we were able to give him, so that, or the physiotherapist we were able to give, because he was having motor problem also, but motor problem was not that much, because of sensory problem he was showing delay development. And we were taking care of sensory issues, and we make him so much defensiveness. We reduced the defensiveness so much less that he was able to allow to be touched by the physiotherapist, and physiotherapist did the motor part, and the child started walking. And he feeling comfortable in the environment. He started enjoying in the with the other therapists, with the therapist who are special educators and all. So that this is how a team works, and this is how we formulate a strategy to handle such children. Similarly, in the beginning I discussed with you about the second child, is the Down syndrome child. And what we did, that we put the child on the ball, that child, but his her feet was touching the ground, so she was secured. And the therapist, myself, was sitting little bit far, but the mother was closer sitting, so she was comfortable sitting like this. Now we were challenging her vestibular system, because she was on the wall, so therapy ball, so all the time the input is going, vestibular input is going, and it is changing. But because the foot was grounded on the foot was not hanging, it was grounded, so she was secured. Mother was there, so she was secured. And very soon she started enjoying such challenges. And then we took her on the rocker board, and then the physiotherapist, they also started working on a strengthening part or moving here and there. And she also started, still she has the issues with vestibular system, because it's not that even with proper intervention it goes completely, it becomes all right. But we are able to get the functions, that's important. So in this way, what we did, we gave the just right challenge. So in a clinical setups, what therapists do to reduce the tactile defensiveness, Wilbarger protocol is there, which is fast brushing followed by joint compression. But practically what we do, we see the comfort level of the child, we gradually introduce other persons into the territory, and we introduce different textures in a playway method. And ultimately we take the child to outdoor locations like park and all. We make them play there in the park. So there are all type of textures are there in the park. Crunchy leaves are there, grass are there, sands are there, soil is there. Then there are vestibular challenges are there swings are there. In the clinical setups you will see a lot of swings, because swings are a fabulous mode of giving vestibular challenge. You can put the child into sitting position, you can put the child into prone position, you can put the child into supine position, in standing position, in any position you can put the child in, challenge his vestibular system. That's why swings are a must in to give vestibular inputs into the clinical setups, and so in the parks. So what we do, so there was active involvement, there was just right challenge, and after every session we see that, oh, what is the response of the child, whether he has become more comfortable or he has not become more comfortable in the surrounding, whether he is happy child or whether he is further deteriorating. So after the session, if the child is happy, if the child is comfortable, if the child is confident, then we know that our therapy is going on in the right line. This is how we manage tactile hyper, as I told you, these are the methods, but these are actually a strategy through which we have to address all this. And one thing is that suppose if you in a clinical setup, many times what we do, if a child comes to us, what we do, we approach the child in a be it physiotherapist, be it occupational therapist, be it a special educator. We do not give consideration, but we approach the child in a very enthusiastic manner. That is a wrong approach. You do not know if the child is defensive or not, so you have to be little bit reserved. Let the child be comfortable with the mother, and when you are sure that the child is not a tactile defensive child, then only you give your hand or you try to touch the child. Because if the child is tactile defensive and you did the initiation, then he will become more defensive. He will think that you are a threatening factor, and he will not cooperate to you within the therapy setup. So the physiotherapist shall take care of this. That in fact, ideally, it should be that when a child is coming to you for therapy session, your hand shall be behind. Your hand shall not be in front, because the child will. If the child will not see your hand, or the child will see that your hand is behind, he will feel more secure that you are not going to grab him, and so later on it will be easy for you to mingle with the child and develop a proper rapport with the child. So this is how we do we reduce gravitational insecurity. Here the key point is that you can use swings, but again you have to see, you have to do just right challenge. You see that he is not uncomfortable on the whatever mode you are using, whether you are using swing or you are using a therapy ball. He shall be comfortable with that. Then little bit start challenging his proprioceptive vestibular system. Now proprioceptive system, as I told that the two functions of proprioceptive is, one is gradation of force, and second is bilateral integration. For bilateral integration, you have to give lot of those activities which requires two sides of the use of two sides. For example, simple activity, catch and throw, or hitting a target in a when the target is static or the target is moving, the child is static or the child is moving. All this all this gives good input of or good awareness of body position in the space, and they are improving the proprioception. And joint sense is improved by using heavy vests, which are heavy jackets, or joint approximation, or doing heavy joint activities, for example pushing or pulling heavy objects, tables and all. You can tell the child to take a cloth and clean the table. That also gives a lot of proprioceptive inputs. So these are you can make him remove the links, because the plastic links, when he removes, he gets proprioceptive inputs on the fingers. Any activity which is pushing and pulling, involvement of pushing and pulling is there, that gives the proprioceptive inputs. And if the child is having diminished sensory registration, then you have to give vigorous movements on the ball, on the you have to give vigorous brushing or something like that, or you have to increase the tactile input or something like that, so that the registration the child's brain shall start registering those inputs. And if the child is seeker type, then you have to utilize those movements. You cannot stop the child that don't jump. or don't touch, because he will crave for more and more. As soon as your watch is over, he will start jumping. So what you have to do, you have to give in a control input. You have to make the child jump on the trampoline for half an hour, then tell him, use it as an incentive, tell him that after half an hour jump you have to sit down and do this activity. So when he will understand that this is an incentive, and if the if he will do this activity, then he will be allowed to jump for half an hour. It's okay for him, he will do the activity. Just I wanted to show you this picture. You see this picture, he is a child who is visually impaired, means blind child, but see how he is holding this rope, and what is the posture. So this is a very good example of proprioceptive and vestibular integration. Very firmly is holding the rope. He is comfortable in this position also, with the leg he is holding the rope. So it is very difficult. I work in blind people association where a lot of visually blind children are coming, and what we discussed today is the processing problem. But in blind children, the vision, the input is itself not there, so they are very much scared, because when you are blindfolded, so you do not know that the सामने में जो है वो क्या है, and it may cause problem to you. So all the time you are scared. So such children are, blind children are all the time scared. So we handle these children with in a different manner. Such sensory problems in which inputs are not there, so naturally, defensive reactions will be too much. Those who are from blind from birth, so they won't like to explore at all. So here we do not give any type of brushing or something like that, but give lot of reassurance and only real positive inputs. So I want to clarify that as a physiotherapist, if you get any child who is blind, please don't follow the conventional method of sensory integration. Only thing here works is real assurance by the parents, by the therapist, and only real exposure of the real objects for sensory input. Suppose if a blind child has come to me and I have to expose him to tactile inputs, then I will give him real orange, real apple. I will not give him a toy apple or toy orange, because he is not looking at that. His vision is not there. So when he will explore a wooden orange, he will form the concept of a wooden orange, and when the actual orange will come, he will get confused, what is this. So in those cases, always you have to use the real objects, real sensory inputs, and lot of reassurances, because his input is not there. So it's not because of processing, but because of the lack of input, they are showing the behavioral problems. With this, I conclude. I hope that for a 1 hour or 45 minutes session, it should be clear. If you have any question, you can ask, or as the Dr. Chaitali is proposed.
Yes, sir. Thank
So
you very much for providing us insights about the sensory issues in the children. You have shared your experiences as well, as you are working with the Blind People's Association, and you are daily dealing with such type of sensory deficit child. And it was really wonderful session. You have explained it in very well manner with all the detail, minute thing explanation. So thank you very much. On behalf of Parul Institute of Physiotherapy, Parul University, I'm really very grateful that you have provided us with the insights. Thank you once again, sir, for a wonderful session.
welcome, welcome,
Thank
ma'am.
you very much. Yeah. Thank you, sir. So we will end the session, sir.
Okay, ma'am. Thank you. Convey my regards to
Thank you.
Bhavna, madam.
Yeah, thank you, sir.
Okay.